All right, welcome to dental board exam. This is integrated national board for dental examination by chemistry review. Okay. All right, so we're going to review the uh, biochemistry in terms of the new format of the exam. And the new format of the exam, they give you a patient. Okay, they give you a patient. um, some of you call them testless or a case. Okay, it's a patient. So a patient comes in with a complaint as a dentist in your office, and they want you to fix their problem. Okay, but to fix the problem, you have to make a diagnosis. You have to evaluate the patient. You have to make sure you take a very good interview and integrate all the medications, all their social history, the past medical history, the past surgical history, and you have to know the benefits of some of the medications they're taking and the adverse effects, some of the interaction, the mechanism of action, and then from there you start treating the patient. Okay, so the the time when you just receive a question without a scenario, that one is gone. So this one is focusing more on the clinical aspect, integrating the the basic sciences and the clinical aspect. Okay, that's what you do as a dentist. That's what you do in your office when the patient comes in. All right, you don't just look at the tool and say, okay, we're gonna do a filling, or we're gonna do the extraction. You go ahead and review the medical history or the allergies, and you treat the patient after reviewing their medical history. Okay. All right, so let's look at the first case here. So this is item practice 1. Okay, so this is the first practice item, and so we have a 54-year-old male patient who comes in with a chief complaint of, I was eating chips last night and now my mouth cannot stop bleeding. So the patient has a past medical history of cardiac stent placement 3 years ago, and currently he takes clopidogrel, which is Plavix, aspirin, and hydrochlorothiazide. And you do an exam and you find that there's anterior floor of the mouth bleeding and pain on palpation. So the question now is, okay, what is the mechanism of action of aspirin? Okay, so meaning you're assessing the entire patient, but while you're assessing and evaluating the medical history, you're asking yourself questions. Okay, these are the questions that are going in your mind, and you are thinking, okay, can I treat this patient safely without causing more bleeding? Okay, and how do you stop the bleeding? All right, so what is the mechanism of action of aspirin? So you know aspirin is a non-steroidal anti-inflammatory, same class as the ibuprofens, okay, and the methasone. Um so A is, does it inhibit cell membrane synthesis? Does it inhibit cyclooxygenase? C, does it prevent formation of leukotrienes? D, does it enhance coagulation? All right. So you can think about the answer, but as you know, the answer. So the question is it, does it inhibit cell membrane synthesis? No. So that's not correct. Okay. Inhibits cyclooxygenase. Cyclooxygenase is also called prostaglandin synthase inhibitor. Okay, because cyclooxygenase. So this is B is the answer here. Okay. Now let's review the aspirin itself. And as we review aspirin, you have to keep in mind that this is similar to ANSYS. The aspirin mechanism of action is similar to those of other NSAIDs. NSAIDs meaning the non-steroidal anti-inflammatory. Why do they call non-steroidal anti-inflammatories? Because most of the time, initially, before the non-steroidals anti-inflammatory drugs, we used steroids. We use steroids to decrease inflammation. We still do, especially after surgery, to prevent any edema or swelling, therefore suppressing the inflammatory process. All right, so that the patient doesn't have a lot of edema or inflammation. So now, when the aspirins and the ibuprofen came in, they reduce inflammation, but because they are not steroids, they are called non-steroidals. Okay, so don't be confused by the name. It's just based on the history and other medications which are used for inflammation. Okay, so let's go back here. So okay, so aspirin. What is aspirin? So aspirin is it's a salicylic acid. Okay, it's an ester of the acetic acid, and it was introduced into medicine in 1899. Now, what are the uses of aspirin? Aspirin is used as an analgesic, meaning it's a painkiller. It's used as an anti-inflammatory drug. Antipyretic, meaning it's used to break fever. All right. If you have high fever, high temperature, you give aspirin, it's going to reduce it. It's also used as antithrombotic. If somebody has an MI or meaning with suspicion of a blood clot, and then you want to give a blood thinner, so antithrombotic. So aspirin is effective in doing that. It also decreases inflammation, which is very good, which is the reason it's good to use in MI. MI meaning myocardial infarction. It's also anti-inflammatory, and the anti-inflammatory and the analgesic effects are similar, okay, are roughly similar to those of other NSAIDs. All right. Now, the most important one is that aspirin itself, okay, is very limited in use. When you use it, when you consider to prescribe aspirin in children, you have to think, okay, can this cause Reyes syndrome? And Reyes syndrome is a very fatal syndrome that occurs, and we are going to discuss Reyes syndrome as a separate entity from this review, okay? All right, so aspirin is used. What are the uses of aspirin? Aspirin is used in patients with history of MI. For example, remember this patient came in and he has a history of a stent placement, okay? So most likely he had some kind of infarction and they placed a stent, or they just found that he had some kind of coronary artery disease and they placed stents. But in MI, you get some aspirin, and also you get other blood thinners such as you can be placed on Plavix after the stents are put in. And you realize most of the patients who come in, they're taking blood thinner. They say they had the stent placed. If they're taking aspirin, you have to ask them whether they're taking any of the blood thinners. Usually the clopidogrel, which is Plavix, is also a blood thinner. It's also it's a antiplatelet also. So Plavix is an antiplatelet. Make sure that you know that most people with MI, usually they take 2 anticoagulants. All right, and usually they take the 2 anticoagulants in the period of, depending on the type of stent which was put in, they can be on those anticoagulants, the 2 anticoagulants, for 6 months, and those 6 months it's usually waiting for the endothelium of the blood vessels to grow and cover the stent. All right, because if the stent is not covered, and the blood is passing through the artery, and then it can cause clots when the clotting factors get in contact with the stent itself, okay, with a naked stent. So you have to give antithrombotics, okay, aspirin and Plavix, to make sure that the patient doesn't form another blood clot. All right. It's also used in angioplasty and angina or angina. Okay, it's used in people with stroke. Now you have to make sure that if the patient told you they had stroke and they're on blood thinners, it means it was an ischemic stroke. Okay, because you have to make sure that the patient doesn't have the hemorrhagic stroke. If the patient had the hemorrhagic stroke, you don't want to give them blood thinners, right? Because you don't want to exacerbate the bleeding. All right. So transient ischemic attack or peripheral vascular disease. That's where the aspirin is used. So make sure you know the uses of aspirin. Okay. So this is very important here. All right. So the activity of aspirin, okay, it inhibits cyclooxygenase, all right, and at the end, towards the end here, we're going to see some of the schematics, okay, of the pathways of cyclooxygenase. It inhibits cyclooxygenase, which is abbreviated as COX, pronounced as COX, okay, and cyclooxygenase is also called, okay, prostaglandin synthase. Okay, so you may find somewhere else where it says prostaglandin synthase inhibitor. Yes, NSAIDs, meaning ibuprofen and all those other celecoxib, the methocin, and the aspirin, they inhibit prostaglandin synthase, which is COX, the COX enzyme. Okay, cyclooxygenase. The function of cyclooxygenase usually is to convert arachidonic acid, okay, to prostaglandin. And arachidonic acid it's a phospholipid, okay? So it's a phospholipid which is produced when the cell membrane, so it's a product of cell membrane breakdown. Remember, you have phospholipase A breaking down the cell membrane, okay? And once the cell membrane is broken down, now you get so the phospholipase breaks down the cell membrane during inflammation. Okay, so for example, you hurt yourself or you bump yourself, the phospholipase is going to be activated and it's going to break down the cell membrane. And you know the cell membrane is composed of phospholipids, and one of those phospholipids is arachidonic acid. And now the cyclooxygenase, which is an enzyme, okay, is going to break down arachidonic acid into prostaglandins, okay. Also, we have lipoxygenase, which is also going to break down arachidonic acid into leukotrienes. So you have to be careful when you give certain drugs, because if you block prostaglandin synthesis, it means arachidonic acid is going to be produced because you haven't blocked phospholipase A. So you can enhance, okay, you can enhance the leukotriene pathway, which is you have to be careful when you give aspirin in asthmatics, okay? So prostaglandin 2, okay, is the first prostaglandin which is synthesized, and it is a precursor to other prostaglandins such as the E and F series of prostaglandins, okay? Cyclooxygenase has two isozymes, meaning it has two types of enzymes, okay? So you have COX, cyclooxygenase 1, and you have cyclooxygenase 2. Aspirin usually, okay, irreversibly, you have to make sure you understand, irreversibly inhibits cyclooxygenase by acetylation of some of the serine moieties in the cyclooxygenase. Okay, remember when it says serine moiety, you have to remember that a serine is it's an amino acid, and you have to remember that enzyme cyclooxygenase, it's an enzyme. Enzymes are proteins, okay, which catalyze reactions. So you have to go back. You don't just, even though this is a clinical scenario, you can see that how you have to understand the basic sciences so that you can better treat the patient. You have to understand your patient, okay? If you're just treating, or you ignore the medication that the patient comes with, then you may cause more harm. And you have to know that you have to know that one of the code of ethics, okay, it's non-maleficence. All right, so you have to, this is the reason you have to understand the patient as a whole. All right, so aspirin is approximately 170 more active on COX-1, all right, more than COX-2. And aspirin, however, does not inhibit peroxidase activity of COX. So the COX enzyme has the activity which breaks down the arachidonic acid, but it also has another activity which is peroxidase activity. All right, so that's not inhibited. Aspirin does not. Make sure you understand this. Aspirin does not inhibit or suppress the synthesis of leukotrienes. Leukotrienes are also inflammatory mediators, okay? And you have to, so if a patient who takes steroids, okay, takes steroids, those steroids are going to block. So steroids prevent inflammation by blocking phospholipase A. All right, so arachidonic acid is not produced. However, in patients who don't take steroids, phospholipase A is still breaking down the cell membrane, and is producing arachidonic acid. Now, if you give NSAIDs, ibuprofen or aspirin, you're going to block prostaglandin synthesis, but you're going to enhance leukotriene synthesis. So in a patient who is asthmatic, these leukotrienes, okay, especially leukotriene 4, it can cause bronchoconstriction. All right. So and then when they have bronchoconstriction in an asthmatic, then you have an asthmatic attack. All right. So you have to keep those in mind, which is the reason some of the Montelukast, those medications, they block leukotrienes, and they're used in asthmatics. All right. Okay. So action of aspirin as antithrombotic. Okay, so antithrombotic action, meaning it's a blood thinner. Okay, it's a blood thinner, and so the way it is an antithrombotic, the way it thins blood, prevents from the blood from clotting, is because aspirin itself inhibits, okay, thromboxane A2, which is abbreviated as TX. All right, it's abbreviated as TX, and all right, some of the actions. So the aspirin induces inhibition of prostacyclin. All right, so thromboxane, all right, is inhibited, and aspirin induces inhibition of prostacyclin. All right, so thromboxane is a potent vasoconstrictor and platelet agonist. So thromboxane, what is the function of thromboxane? Thromboxane is a platelet aggregator. It increases blood clot. All right, but because aspirin and other NSAIDs such as ibuprofen, they inhibit thromboxane. So the blood does not clot because there's no platelet aggregation. All right. So prostacyclin, all right. So prostacyclin here usually inhibits platelet aggregation and vascular smooth muscle contraction. All right. So thromboxane and prostaglandin I, they have opposing effects on homeostasis, okay, or hemostasis. So the COX enzyme, inhibition of the platelet is irreversible, as we mentioned, due to limited amount of mRNA and protein synthesis in these cells, all right, in the platelets. And the antithrombotic action of aspirin is primarily mediated by COX enzyme, all right. So the majority of this is the COX enzyme, and the COX enzyme usually produces thromboxane, and thromboxane, as we mentioned, it enhances platelet aggregation, which causes blood to clot. Okay. All right. So the unplatelet effect of aspirin usually results in a prolonged bleeding time. So if a patient, so this patient who comes in says, I'm taking Plavix, which is a blood thinner. I'm taking aspirin. And then the question, if another question comes in and say, okay, if you want to order a blood test, what kind of blood test would you order? Okay, to see how these patients' platelets are functioning in terms of bleeding. Okay, so you order, you check for bleeding time. You order a bleeding time on the patient. Okay, you are not going to order PT or PTT. All right, so don't be caught. Don't be fooled. If somebody is taking aspirin and Plavix, you don't check for PT or PTT or INR. All right, you check for the bleeding time. All right, so usually the bleeding time of after the patient takes aspirin returns to normal roughly 36 hours after the last dose of the drug. So this is very important when you ask somebody to stop taking the blood thinner because you don't want them to bleed. So you know that within 36 hours, okay, then their bleeding time will come back to normal. But then again, we're going to discuss why would you ask the patient to stop aspirin? All right, when you are working on them as a dentist, you have a lot of agents which you can use, or techniques which you can use to stop the bleeding when you're working in the patient's mouth. Okay, all right. So the aspirin may also decrease the progression of atherosclerosis. All right, if somebody has atherosclerosis, you find them that they're given aspirin, and this is to protect LDL from oxidative modification. All right, and therefore it improves endothelial dysfunction in atherosclerotic vessels. So more recently, it has been proposed that the beneficial effect of aspirin in myocardial infarction prophylaxis might be related to the ability of the aspirin to reduce circulating levels of CRP, okay, C-reactive protein. So in a very high and toxic doses, aspirin exerts a direct, so if somebody is overdoses on aspirin, aspirin is going to exert a direct inhibitory effect on vitamin K. All right. So aspirin usually inhibits the COX enzyme, but if you overdose on it on high doses, it's going to inhibit vitamin K dependent hemostasis by inhibiting the synthesis of vitamin K dependent clotting factors. All right. Also, at high doses, prothrombin synthesis is impaired, resulting in hypoprothrombinemia. All right. So how does the anti-inflammatory effects of aspirin, all right? So the anti-inflammatory action of aspirin, as we mentioned, is believed to be as a result of peripheral inhibition, okay? So it's peripheral inhibition of the COX-1 and COX-2. COX-2, cyclooxygenase 2, is inducible in the setting of inflammation by cytokines, all right? And so when you inhibit cyclooxygenase 2 by aspirin, you're going to suppress the production of prostaglandin E and F. All right. Usually the prostaglandin E and F, they induce vasodilation. All right. They induce vasodilation and they increase tissue permeability. All right. So prostaglandin, make sure you understand this. All right. Prostaglandins E and F, they increase vasodilation. When the vessel has dilated, okay, it is a high risk of if it has dilated, then you have increased blood flow to that area. Increased blood flow to that area, and then you have more of hydrostatic pressure. More hydrostatic pressure, then you're going to have edema, okay, all right, and swelling. Okay, so prostaglandins E and F, they cause vasodilation, all right, and they also cause the influx, as I told you, the blood flow to the area, and the blood also brings in the leukocytes, the white blood cells, all right. So that's how inflammation works. So ultimately, the classic symptoms of inflammation result in swelling, okay, redness, warmth, and pain. All right. And sometimes inflammation can lead to loss of function. All right. So you have to know the 4 to 5 principles of inflammation. Okay. And some of their Latin names, I mean. So the aspirin decreases capillary permeability, so thereby reducing swelling and inflammation because it reduces inflammatory mediators influx. All right. Aspirin can also reduce the release of destructive enzyme from lysozyme. So how does aspirin act as a painkiller? How does it prevent pain? Okay. So salicylates are effective, okay, in cases where inflammation has been caused sensitivity of pain receptors. Okay. So if there has been sensitivity of the pain receptors by inflammation, aspirin can reduce that pain. It appears that prostaglandins, specifically prostaglandin E and F, as we just discussed, that E and F are very important in increasing inflammation due to vasodilation, okay? They are responsible for sensitizing the pain receptors. So if you're blocking prostaglandin E and F, that means you're going to reduce pain. Salicylates, okay, they also have an indirect analgesic effect by inhibiting the production of prostaglandin. All right, so it's an indirect effect. So the analgesic part of aspirin as a painkiller, it is indirect. Okay, it does not directly affect hyperalgesia or the pain threshold. All right. So salicylates may also interfere with pain perception centrally by acting within the hypothalamus. So they prevent the way you perceive pain, meaning the sensory input from the hypothalamus is blunted So your pain perception is decreased. And the total serum salicylate levels, which are associated with the analgesia and antipyretic, meaning if you want to decrease fever, usually it's about 30 to 100 micrograms per ml, okay, per milliliter. So how does the aspirin act as anti-fever, meaning it's used to break fever? And what is the effect of aspirin or other NSAIDs, all right, such as ibuprofen, on the GI, all right? So salicylates, they promote a return of the body to normal temperature, okay, in the hypothalamus, okay. They suppress, they do this by suppressing the synthesis of prostaglandins, specifically prostaglandin E2. The adverse, this is very important, okay, the adverse effects from salicylates may be mediated through the decreased prostaglandin synthesis due to inhibition of COX-1, all right? So COX-1 is the main actor here, okay? And salicylates increase the permeability of gastric mucosa to cations. Cations are positive ions, all right? Therefore, it increases the entry of the acid, okay? What's the acid in the stomach? Hydrochloric acid, all right? So it increases the permeability of hydrochloric acid into the mucosa. The salicylates are also known to stimulate the chemoreceptor trigger zone. If you activate, okay, chemoreceptor or stimulate the chemoreceptor trigger zone, you're going to cause nausea and vomiting. And a lot of, you know that a lot of medications cause nausea and vomiting, and this is how they're affecting it, okay? By centrally acting on the chemoreceptor trigger zone, it can induce nausea and vomiting, all right? Okay. So, the pharmacokinetics of aspirin. What are the pharmacokinetics of aspirin? Okay. So the salicylic acid is widely distributed with high concentration in the liver and kidneys. And the salicylic acid crosses the placenta. So make sure you have to be careful what medications you are giving to children and also expecting mothers. All right. What do you give to expecting father? Well, I believe you're an expecting father. You can believe you can give them NSAIDs, okay? Because that's not going to affect the baby. However, an expecting mother or a mother who is breastfeeding, you have to be careful because most of the aspirin is excreted in breast milk, and during chronic administration, for somebody who's taking it a long time, the salicylate levels, they are found to be higher in the fetus than in the mother, all right? So be wary. And remember, if the mother is taking aspirin, then it can cause early closure of actually it can prevent early closure of the foramen ovale, okay? The foramen ovale, not the one in the skull, okay? Remember, the atrium also has, of the heart, has foramen ovale, and you need prostaglandins for that foramen ovale to close, okay? So when you give aspirin, then you can have what you call patent ductus arteriosus, okay? So you're going to have a communication between the atria of the heart. So you don't give the aspirin, okay? Aspirin has a half-life of 15 to 20 minutes, okay, in adults, because it is hydrolyzed by the liver to salicylic acid. And salicylic acid is primarily metabolized by the liver, okay? So two main points, all right? And so 80 to 100% of salicylic acid from a single salicylic dose is excreted within 24 to 72 hours in urine. Now, here comes the interesting part, how salicylic acid is absorbed. Okay, if the pH is too high, for example, you take a pill and your stomach pH is high. Of course, we all know that the stomach pH is usually low. The stomach pH, if it's high, is going to increase absorption, okay, absorption of the aspirin. All right. And so also the effect is similar when the aspirin is being, or the salicylic acid is being excreted through urine. So you have to make sure you know this principle. The excretion of free salicylic acid is variable and depends on the dosage and the urine pH. All right. In alkaline, here, let me go slow here. So in the alkaline urine, over 30% of the dose, okay, of aspirin may be eliminated as free salicylic acid. So in alkaline, over 30% is excreted as free salicylic acid. But in acidic urine, okay, only 2% of the aspirin is eliminated as free salicylic acid. Okay, so if the urine pH is too high, all right, then you are going to eliminate, okay, you're going to excrete more of the aspirin or the salicylic acid. Okay, so in alkaline urine, the acidic metabolite of aspirin is going to be excreted. In acidic urine, you're going to have more absorption, so less of the aspirin or the salicylic acid is going to be absorbed. I mean, less is going to be excreted. Okay, so this principle here, you have to understand it. Okay, so what is the overall effect of increased pH on the absorption? Okay, is that you increase the pH, then you're going to increase absorption of the aspirin, of the salicylic acid. Okay, increased pH is going to increase absorption. All right. So I hope you understand this principle. Okay. All right. So here we're going to go through some of these schematics. These schematics are found in several articles, especially this schematic is found in many articles. So now this one, we're going to discuss about how the arachidonic acid is metabolized. Okay, so you have a cell membrane, and the cell membrane is made up of a bilayer of phospholipid. Don't forget your biochemistry or your cell biology, okay, and the architecture of the cell. So you have to understand all those. That's why you have to be, as a clinician, you can't just go about, okay, doing certain treatments without understanding the mechanism of what you're treating. Okay, so the cell membrane has phospholipids, and those phospholipids, whenever you hit yourself or hurt yourself, then it hurts. Okay, and that induces inflammation, meaning it also activates phospholipase A. Phospholipase A is an enzyme which breaks down these phospholipids, okay, in the cell membrane. And the breakdown of phospholipids in the cell membrane is going to produce arachidonic acid, okay? So, arachidonic acid. Now, the arachidonic acid metabolism, or the breakdown, that's what metabolism means. Okay, metabolism is a breakdown, or also has two components, catabolism or anabolism. Okay, so there are several, okay, pathways of arachidonic acid metabolism, all right, which are affected by drugs. For example, you can see, you can go the pathway which produces leukotrienes, this one here, and there's a pathway which is induced by cytochrome P450, all right, to produce epoxides. Okay. And remember, epoxide, the interesting part is that epoxide, if you remember carefully, okay, there's an enzyme which needs vitamin K, which is vitamin K and calcium affect epoxides. So the epoxides, they are very important in terms of blood clotting, all right, in vitamin K dependent factors. And as we mentioned, if you give too much of aspirin, you're going to block, all right, you're going to block some of these vitamin K dependent coagulation pathway, okay? So you have to make sure you understand all these things. All these things are linked together, and you have to understand the medication, okay? And the more you understand, the more confident you become in these exams, okay? If you don't understand, you're mostly just memorizing without understanding the reason why you are doing certain things, okay? And if the patient asks you why you are doing certain things, you don't have to make up anything. You just have to give him the science, okay, of why you are doing certain things, all right? So, if you give aspirin and other non-steroidal anti-inflammatory drugs, they're going to inhibit cyclooxygenase pathway, okay? So cyclooxygenase pathway is this one here. And if you give aspirin, aspirin is going to block, okay? It's going to block. So you give aspirin or NSAID, okay? NSAID. It's going to block cyclooxygenase. If you block cyclooxygenase, all these prostaglandin, as we mentioned, prostaglandin G2 is the first prostaglandin to be synthesized, okay, in the breakdown of arachidonic acid. All right. So you're going to block this. If you block this prostaglandin G2, then you cannot have any other prostaglandin produced. So all these prostaglandins are going to be blocked. Okay. Okay. All these are going to be blocked. All right. So now we mentioned prostacyclin. Prostacyclin, all right. Prostacyclin synthase breaks down prostaglandin H to prostacyclin. Now remember, prostacyclin usually causes platelet not to aggregate. So it inhibits platelet aggregation. Prostaglandin I, okay, or prostacyclin inhibits platelet aggregation. It causes vasodilation, and it causes renal homeostasis, okay, induces pain and inflammation, all right? Now, if you give aspirin, you are going to block the activity of a prostacyclin. You're also going to inhibit the actions of the prostaglandin G, so prostaglandin D2, prostaglandin E, and F, all right? So prostaglandin F, look at that. Prostaglandins are very important, very key in reproduction. The prostaglandins are very protective, okay? Prostaglandins are key in terms of GI cytoprotection, all right? Also, they can cause fever, renal homeostasis, pain, inflammation, as we know, okay? So you have to make sure that you know the pathways of how, when you give aspirin or ibuprofen, how the pathway is going, okay? Now, when you block the immediate effects, okay, if you block the arachidonic acid breakdown, you can block the immediate effects of mast cells degranulation, Okay, and some of these drugs, such as aspirin and non-steroids, they they do not block, they don't block lipoxygenase. Okay, so the lipoxygenase is not blocked by aspirin. Okay, so you can increase production of leukotrienes and can lead to exacerbation of asthma due to delayed uh, mast cell degranulation. So it causes mast cell degranulation, causes more of leukotrienes, and it exacerbate asthma. And this is another of a schematic showing some of the drugs. So as I mentioned before, so the leukotrienes, okay, the leukotrienes are affected by, let's see, so the leukotrienes are affected by um, the production of the steroids, corticosteroids, because they prevent, okay, the action of phospholipase A. And NSAIDs, they block COX, the COX enzyme, okay, cyclooxygenase. All right, let's see what else we talked about. Okay, so these are just another schematic, and you can see cyclooxygenase oxygenase here, okay, leads to production of leukotrienes, all right, and some of these leukotrienes, they also break down and they are inhibited by the leukotriene D4. It's inhibited by Montelukast, okay, or singular, okay. So singular affects the production of leukotrienes. Okay, this is another schematic. I'm not going to linger on this one. This is just to show you so that you have more of schematics. All right, so when you see it, you don't forget. All right, so aspirin blocks action of cyclooxygenase, blocks the cyclooxygenase pathway by inhibiting COX-1 and COX-2. All right. All right, so this is a schematic which gives a very short summary of what you need to know. Okay, so arachidonic acid, which is also is produced by from mast cells or eosinophilic activation or degranulation. All right, and this leads to activation of cyclooxygenase, okay, which is the immediate pathway. Now, the production of leukotrienes is in a delayed pathway, as you can see, okay. So this gives you a nice summary of what we discussed. And the cyclooxygenase pathway is going to give you prostaglandins, okay, and thromboxane, and these prostaglandins are going to, if they're going to inhibit, okay, the Th1 response, and the thromboxane usually causes vasodilation. If you cause vasodilation, you're going to increase blood flow to the area. Also increases vascular permeability and causes bronchial smooth muscle contraction. Make sure you remember that, okay? And the leukotrienes also, they cause bronchial smooth muscle contraction. Thromboxane causes bronchial smooth muscle contraction. The platelet activating factor is very good for chemotaxis and activation for neutrophils and eosinophils. Okay. All right. So this is the end of the review. as a case. So you can see that how a patient, we can go on analyzing this patient coming up with a different scenarios, and we are going to discuss this patient as we go on in terms of the review and practices. Okay,